Hello. Today we will talk about small topics about radial head fractures. First, the anatomy. The capitulum and radial head are reciprocal curved. Force transmission across the radiocapitellar articulation takes place at all angles of elbow flexion and is greatest in full extension. For rotation of the head of the radius require accurate anatomical position in the lesser sigmoid notch. The radial head plays a role in valgal stability of the elbow, but the degree of conferred stability remains disputed. The radial head is secondary restraint to valgus force and seems to function by shifting the center of varus valgus rotation laterally. So the moment arm and force on the medial ligaments are smaller. Clinically, the radial head is most important when there is injury to both the ligamentous and muscle tendon units about the elbow. The radial head acts in concert with the interosseous ligament of the forearm to provide longitudinal stability. Proximal migration of the radius may occur after radial head excision if the interosseous ligament is disrupted. Next, the mechanism of injury. Most of these injuries are the result of a fall onto the outstretched hand. The higher energy injuries representing fall from a height or during sports. The radial head fractures when it collides with the capitulum. This can occur with a pure axial load, with a posterolateral rotatory force, or as the radial head dislocates posteriorly as part of the posterior montagia fracture or posterior olecranon fracture dislocation. It can be a part of fractures of the montagia or olecranon fracture dislocation. It's frequently associated with injury to the ligamentous structure of the elbow. It is less commonly associated with fracture of the capitulum because capitulum is stronger. Clinical evaluation. Patient typically present with limited elbow and forearm motion and pain on passive rotation of the forearm. Well-localized tenderness overlining the radial head may be present, as well as an elbow effusion. The ipsilateral distal forearm and wrist should be examined. Tenderness to palpation or stress may indicate the presence of an A6 lobe wrist lesion, which means radial head fracture dislocation with associated interosseous ligaments and distal radioulnar joint disruption. Medial collateral ligament competence should be tested, especially with type 4 radial head fracture, in which valgus instability may result. Aspiration of the hemoarthrosis through the direct lateral approach with injection of lidocaine will decrease acute pain and allow evaluation of passive range of motion. This can help identify mechanical block to motion. So you will put a lidocaine and see if he can move. That means no mechanical block, only the pain. Radiographic evaluation. Standard AB and lateral radiograph of the elbow should be obtained with the oblique view, green span view for further fracture definition, or in case in which fracture is suspected but not apparent on AB and lateral views. A green span view is taken with the forearm in neutral rotation and the radiographic beam angled 45-degree cephalad. This view provides visualization of the radiocapitellar articulation. Non-displaced fracture may not be radially applicable, but they may be suggested by positive fat pad sign on the lateral radiograph, especially if clinically suspected. Complaints of forearm or wrist pain should be assisted with radiographic evaluation. CT may be utilized for further fracture definition for preoperative planning, especially in case of comminuted or fragment displacement. Classification here is called Mason. Mason classification have 4 types. Type 1, non-displaced fracture. Type 2, marginal fractures with displacement. Type 3, comminuted fractures involving the entire head. Type 4, associated with dislocation of the elbow. So it's very easy. Type 1, non-displacement, marginal fracture with displacement, comminuted fracture involving the entire head, and the last one associated with dislocation. Treatment goal. correction of any block to forearm rotation, early range of motion of the elbow, stability of the forearm and elbow, limitation of the potential for ulnohumeral and radiocapitellar arthrosis, although the latter seems uncommon. Treatment: non-operative. Most isolated fractures of the radial head can be treated non-operatively. Symptomatic management consists of a sling and early range of motion 24 to 48 hours after injury as pain subsides. Aspiration of the radiocapitellar joint with or without injection of local anesthesia have been advocated by some authors for pain relief. Persistent pain, contracture, and inflammation may represent capitellar fracture, especially osteochondral, that was not appreciated on radiograph and can be assessed by magnetic resonance image or CT, I think. Isolated partial radial head fracture. The one accepted indication for operative treatment of a displaced partial radial head fracture, Mason type 2, as a block of 2 motion. This can be assessed by lidocaine injection into the elbow joint. A relative indication is displacement of a large fragment greater than 2 mm without a block 2 motion. So for grade 2, it's conservative treatment only if there is block. For relative indication, if the large fragment with grade 2 Mason fracture. Cochlear exposure can be used to approach the radial head. One should take care to protect the uninjured lateral collateral ligament complex. The anterolateral aspect of the radial head is usually involved and is radially exposed throughout these intervals. After the fragment has been reduced, it is stabilized using 1 or 2 small screws. For partial radial head fracture as a part of a complex injury, this is the pronoun. Partial head fragments that are part of complex injury are often displaced and unstable with little or no soft tissue attachment. Open reduction and internal fixation is performed when stable, reliable fixation can be achieved. For unstable elbow or forearm injury, it may be preferable to resect the remaining intact radial head and replace it with a metal prosthesis, as we take it before with dislocation. Fracture involving the entire head of the radius. When treating a fracture dislocation of the forearm or elbow with an associated fracture involving the entire head of the radius, open reduction and internal fixation should only be considered a viable option if stable, reliable fixation can be achieved. Otherwise, prosthetic replacement is indicated. The optimal fracture for open reduction and internal fixation has 3 or fewer articular fragments without impaction or deformity. Each should be of sufficient size and bone quality to accept screw fixation, and there should be little or no metaphyseal bone loss. So for most cases you want to do prosthetic replacement. The optimal fracture for open reduction and internal fixation only when there is fewer fragment without impaction or deformity. So if there is impaction or deformity, you have to make prosthetic replacement. Once reconstructed with screw, the radial head is secured to the radial neck with a plate. The plate should be placed posteriorly with the forearm supinated, otherwise it may impinge on the lateral and restrict forearm rotation. So it should be from the posterior, so to be safe far from the joint. Radial head excision. The level of excision should be just proximal to the annular ligament. A direct lateral approach is preferred. The posterior interosseous nerve is at risk with this approach. Patients generally have fewer complaints, mild occasional pain, and nearly normal range of motion. The distal radioulnar joint is rarely symptomatic, with proximal migration averaging 2 mm except with associated A6 laparosty lesion. Symptomatic migration of the radius may necessitate radioulnar synostoses. Late excision for Mason type 2 and 3 fracture produce a good to excellent results in 80% of cases. Now we want to talk about A6 laborosity lesion. This is defined as longitudinal disruption of the forearm interosseous ligament, usually combined with radial head fracture and or dislocation plus distal radioulnar joint injury. It is difficult to diagnose. Wrist pain is the most sensitive sign of distal radioulnar joint injury. One should assess the distal radioulnar joint on lateral X-ray view. Treatment requires restoring stability of both elbow and distal radioulnar joint component of the injury. Radial head excision in this injury will result in proximal migration of the radius. Treatment is repair or replacement of the radial head with evaluation of the distal radioulnar joint. With stable fixation, it is essential to begin early active flexion, extension, and pronation supination exercise. Complication. First, contracture. This may occur secondary to prolonged immobilization or in case with unremittent pain, swelling, and inflammation. Even after seemingly minimal pain, this may represent unrecognized capitellar osteochondral injury. After a brief period of immobilization, the patient should be encouraged to do flexion, extension, supination, pronation exercise. The outcome may be maximized by formal supervised therapy regime. So contracture, this is very common around the elbow especially. Chronic wrist pain may represent an unrecognized interosseous ligament, distal radioulnar joint, or triangular fibrocartilage complex injury. Recognition of such injuries is important, especially in Mason type 3 or 4 fractures in which radial head excision is considered. Proximal migration of the radius may require radioulnar synostosis to prevent progressive migration. Next, post-traumatic osteoarthritis, and this may occur especially if the presence of articular incongruency or with free osteochondral fragments. Next is reflux sympathetic dystrophy. This may occur following surgical management of the radial head fracture. And last thing, missed fracture dislocation, which means occult fracture dislocation of the elbow, may result in a late dislocation owing to a failure of address-associated ligamentous injuries of the elbow. And that's it.